the person that I'm getting intubated awake for hemodynamics is generally the RV failure patient or the person who's at risk of RV failure, like somebody who's got a really tight mitral valve or something, and you're going to precipitate a pH crisis if you do it poorly. Those are the people that I think need to be intubated awake. And the controversy is not, in my opinion, is that the safest thing for them. The controversy is, am I willing to do it? Because I don't intubate awake very often. I don't really have that skill. This is a stressful situation. I want to fall back on what I do well. So to me, that's the controversy. And this is across the board, right? Anesthesiologists are arguing about this because they're not intubating awake. Emergency physicians aren't intubating awake. We're not doing it all that often. So should this be a core skill that we all do, or should this be a small group of people that become experts at it? To me, that's the controversy.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Dr. Nick Mark.
And as always, I'm your other host, Dr. Cyrus Askin. Nick, I guess you're kind of in the middle of some work right now. I see some bags under your eyes. What's going on there?
Yeah. Just a busy week of nights as usual. Good stuff.
Which hospital? Are you at the busier of the hospitals that you work at, or?
Yeah. So
okay.
Like crashing people on ECMO at 3 a.m. and stuff like that. But
nice.
Keeps me old.
Absolutely. No, I love that. Yeah. No, I'm still trying to transition from a week of nights myself. And like we were talking about in pre-recording, it was exciting last couple nights with some interesting airway things, which actually is fairly topical given the discussion.
The perfect segue.
Yeah. What are we covering today, Nick?
So we've got an exciting show lined up. We're going to be talking about airway controversies.
Yes, very, very good. Yeah. So, we've of course talked about airways in the past, physiologically difficult airway. We've talked about the anatomically difficult airway. We've talked about airways in the context of things like hemoptysis, GI bleeds, etc.
Yeah. And in all of those, we kind of presented our opinions as if they were lore, which is great. Or a fact, I should say, but I think, we wanted to sort of acknowledge the idea that like there might be controversies out in the space. So we wanted to bring on somebody who was an expert, and we could kind of talk through some of the more common areas of disagreement.
That's right. I mean, I think Nick, you and I often do agree on our approaches, and might lend people to believe there's only one way to skin that proverbial cat. But yeah, I totally agree. I think this is a good idea to bring someone else into the fray.
Someone who literally wrote the book on this topic. So I think it's going to be an awesome episode. People should get excited for this.
That's right, guys. Get excited, and hopefully you'll enjoy this episode. All right. So without further ado, guys, I want to introduce our guest. We're super excited to have Dr. Jarrod Mosier here, who's a professor of emergency medicine and medicine at the University of Arizona College of Medicine in Tucson. He's an intensivist. He's ECMO director. He's a researcher. And he also happens to be the critical care course director for the Difficult Airway Course, Critical Care.
Jarrod, great to have you on the show.
Thank you. Thank you for having me.
So you wear many hats. Why don't you tell us about some of the many ball hats you have?
Sure. Well, I am at the University of Arizona in Tucson, and my academic home is emergency medicine. I'm the vice chair of research in emergency medicine. Clinically, I am an intensivist, and I work almost full-time critical care because I love seeing patients. All the rest of the stuff is fine and fluff, and I enjoy doing that, but I love taking care of patients. So I don't ever want to be the guy that has to be protected by a third-year fellow or something.
They sort of wheel you out into rounds, and then
exactly.
wheel you away when something, when stuff's in the fan.
When's the last time Dr. Mosier intubated a patient? We have to, which year was that?
Yeah, exactly. I am the ECMO director for our ECMO service, and then my research interest started off with airway stuff, and then over the course of my career, it's kind of migrated down the airway into ARDS, respiratory failure stuff. And then
you aspirated.
Yeah, exactly. And then I'm the course director for the Difficult Airway Course, Critical Care.
Okay, and let's talk a little bit about that. Our listeners who maybe have listened to us for a little while now, they've heard the mid-roll a couple times where we've been talking about the Difficult Airway Course. If we've still got folks that are on the fence, not sure if they want to jump into that course, what do they have to look forward to if they make the plunge?
Yeah, well, we get asked all the time, what's the difference between the emergency course, the anesthesia course, critical care course? And the difference is that each of those, there's a lot of overlap, right? The principles are the same depending on where you are. But really, the each of those areas has its own unique literature, its own unique patient populations, its own unique spin on the way you need to handle things. I mean, my thing is the physiologically difficult airway. Everybody faces that, yes, but we face it to a much more concentrated and higher severity degree in the ICU. And so in the critical care course, we really focus on how to handle that. So in the emergency course, it really is focused on, okay, who and how do you RSI, if I had to boil it down to its most basic building block. In the critical care course, we do cover that, but it's also how do you best pre-oxygenate somebody? How do you handle the hemodynamics? How do you use ultrasound to do that? And who do you not RSI, and how do you approach that? How do you take somebody off a ventilator without safety issues, that kind of thing?
Yeah. I got to say, I'm a big fan of the book that goes along with that.
Oh, thank you. That was a 2-year gestation period trying to get that baby born.
Wow. That's for our listeners who love animal physiology facts. That's like an elephant's gestational period. Yeah, I very impressed by the sort of mixture of like high level stuff, like the sort of who should you do this in, how should you think about this, how do you sort of prepare a team, leadership stuff, but also like very low level stuff, like put the lidocaine in your pocket so it's warm so it flows more easily. Like,
Yeah.
it's a good book.
Oh, I appreciate that.
Yeah,
I wanted to
really.
do it a little bit differently where, okay, you here's what you should do, and then here's why you should consider doing that. And then I was
Mm,
telling Cyrus earlier, the thing I'm most proud of is I wanted to make sure there was a consistent theme across the entire book. And so at the end of each chapter, there's these editor commentaries where I tried to weave a consistent theme
yeah,
uh, across the whole book.
the cliff notes, if you will.
Yeah, exactly.
I have one question before we get into kind of the airway controversies, and
Yeah.
I'll hand it off to Nick to sort of take us on this guided tour. But I have identified this phenomenon amongst emergency intensivists or EM crit docs, where like they never want to work in the ER ever again. Like it's like after they've done their critical care training, they're like done with the ED. And I was wondering if you could just shed a little light on that.
That's a great question. And
That is a great controversy question.
yeah, no, no, no. I mean, my primary specialty might get upset at me for this answer, but the answer, this happened to me, right? I mean, everybody who goes into fellowship, we've all said since the beginning of time the same thing. Everyone still says the same thing. I want to do 50-50 EM and critical care. And almost nobody ends up doing that if they have the opportunity to not do that. And for me, I think it was sort of twofold. One was as my subspecialty started gaining traction academically, and I get protected time for this, that, and the other, I'm not going to take it out of my subspecialty. So you start taking it out of your primary specialty, and then pretty soon you're not doing any PZD shifts, you're not doing urgent care stuff, and then you're not reducing fractures and that kind of thing. And so then you start asking, well, what exactly am I? And then you're not reading the literature, right? I mean, I don't really care that much about the heart score and that kind of stuff anymore because it's not what I want to focus on.
So yeah, not really germane to your day-to-day practice
Yeah,
anymore.
exactly. The second thing is that, what we all love about emergency medicine is the critical care part. And what's being required of emergency departments is less and less of that. And so
Mm,
what seems to be bubbling to the surface is that the emergency is the number of people that need to be seen on an individual patient. And so
mm,
your priority ends up being the bed the patient's in because there's 50 other people that need that bed and whatnot. And that for me, that just wasn't as satisfying as I
mm,
wanted. And you don't know that until you get away from the specialty and get a look back at it from the outside to
mm.
really kind of put your finger on that. So I think that's why people tend to migrate out.
So you mean to say that every shift in the ED is not like an episode of The Pit?
I've never seen the pit. I've heard
Uh,
about the pit, and my guess is that yeah,
perhaps not.
We'll,
Yeah, I can assure you that.
we'll have to have you back on the show after you've watched it. We should.
Yeah,
my
great
wife is an
show.
emergency nurse, and she wants me to watch it with her, and I go, why would I want to watch that? I've lived it. Why do I want to watch it?
I think it's really. I don't want to go too far off in the weeds, but it's probably of all the medical shows I've ever seen, it's far and away my favorite, and probably the most. I don't know. It has like the most legitimacy in my mind, with air quotes, for what that's worth.
Well,
So,
Noah Wiley's always going to be John Carter to me. I mean,
yeah,
ER was right in my sweet spot of what do you want to be when you grow up, and so he's always going to be Carter.
I love
Yeah.
it.
Well, it's interesting because he's sort of like grown up, jaded, kind of, messed up Carter now.
Exactly what
It's
Carter would be if he were still,
yeah,
if he were still
yeah,
practicing.
exactly.
That's right. So Nick, I think we probably, shot the breeze enough, in our audiences, if they're still listening, they probably want us to get to the, meat and potatoes here. So why don't you take us over to the main course?
Well, actually, before I do, I'll just say that I think you and I are overdue to do a fun episode where we listen to some clips of these shows and we react to the medical realism of them. So for our
Yes.
listeners who hate when we chit chat, skip that one. For those who like it, the roughly 50% who say that's their favorite part of the show. Get excited. Anyway, moving on. In this episode, sort of the main course we're going to talk about is airway controversies. And I thought one way to organize them is we could sort of start at the beginning chronologically. Controversies before intubation, things like pre-oxygenation, choice of medications to draw up, and then move on to during intubations, choices of like approach, equipment, and then maybe move on to some stuff like kind of after too as we go. So anyway, should be fun. We're gonna do like probably at least 6 or 7 of these, so it should be kind of rapid fire. I will kick us off with our first one, which is about pre-oxygenation. So there's been, quite a few studies in recent years, kind of what is the best way to pre-oxygenate people. We had the PREVENT trial in 2019. We had the pre-oxy trial in 2024, finding sort of different devices are better. High flow sort of had its day. Jarrod, I'm curious what your thoughts are on pre-oxygenation. Is there one size fits most? Is there one approach that's better than others?
One ring to rule them all, if you will.
I guess if you back up and you look at what is the point of pre-oxygenation, it's to build a reservoir of oxygen so that you can keep resaturating hemoglobin during apnea, right? And so what do you need to be able to do that? You need a volume of gas, which would be your functional residual capacity. And that can be either externally or internally reduced, right? Externally by either obesity, ascites, a late trimester pregnancy, pleural effusions, that kind of thing, or internally compressed with airspace disease, pulmonary edema, that kind of stuff, right? And so if any of us needed to be intubated, we have a sufficient functional residual capacity that if we became apneic and that was fully oxygen, we'd be fine, right? But in our critically ill patients, based on whatever their underlying problem is, may or may not have a significantly reduced functional residual capacity. The second thing you need is that volume needs to be oxygen. And so you have to fully denitrogenate that. And the way we were taught in the past was always 8 vital capacity breaths or 3 minutes of tidal volume breathing on a non-rebreather. We have sort of extrapolated that from the OR to the non-rebreathers we have, which are not actually non-rebreathers, right? You're not rebreathing CO2, but the higher your inspiratory effort, you have a fixed flow across that valve from the bag across the non-rebreather, and so you're just going to be sucking in room air. So the higher your inspiratory effort, the worse it works, unless
So the people who need it the most are getting the lower FiO2.
That's right. Yeah. And you can measure how well you're denitrogenating by measuring the end-tidal O2 with a exhale gas monitor. And I wrote a paper a number of years ago about what are the different ways of pre-oxygenating lead to your end-tidal O2. And so if you have a tight circuit, obviously you fully denitrogenate, assuming it's 100% oxygen. But the non-rebreathers we use, you lose half of that. And so if your FRC's down, automatically you're starting off behind the 8 ball, and then only half of that's oxygen. And then if you put somebody on BiPAP, at the time I wrote it, we didn't know what high flow did. Now we know high flow gets you close to what BiPAP would get you, or a tight fitting mask. So you can fully denitrogenate somebody with either of those non-invasive respiratory support modalities. But if you use flush rate oxygen, where you open the valve all the way to where what's limiting the flow is the hospital's pressure behind their oxygen system, then you're constantly pushing oxygen across that valve, and you can denitrogenate them almost completely like you would if you were using high flow or BiPAP. Brian Driver did that work and showed that it's substantially better. So there's those two things. Now, a sub part of that is that if you take away the oxygen source before they're fully apneic, they're just breathing nitrogen, right? And so you're going to lose a lot of that you'll re-nitrogenate. And I noticed this when I was playing around with the airway gas monitor, that it's really easy to re-nitrogenate somebody.
So this is like this is a situation where like you've done a great job, you have a tight fitting mask or high flow or something, and then the person's not fully apneic and somebody takes the mask off.
Yeah, you push drugs, you're standing at the head of the bed, you're ready to go.
And somebody's trying to help you and they take it off too soon.
Off. Couple agonal breaths, right? You lose a whole bunch of the work you just worked hard for. And so if you keep the oxygen source on until they're fully apneic, then you're okay, right? And then that I call it partial apneic oxygenation, where you're either mask ventilating or something, or keeping the BiPAP on until you're ready to do laryngoscopy, or full apneic oxygenation, where you have oxygen through the whole period. The third thing that you need is that you need a shunt fraction that's low enough to where that's actually interfacing with hemoglobin as it goes through the pulmonary circulation. And so I think if you want to talk about what's the best modality, the thing that gets you most of those things the most often is probably going to be non-invasive.
Right.
If you have somebody whose rate limiting step is denitrogenation, then a flush flow non-rebreather I think is fine. If their rate limiting step for success is functional residual capacity, then you need some kind of non-invasive respiratory support. But if the rate limiting step is shunt, that's much harder, right? Because it's much harder to fix that if you can't recruit. And so for me, I mean, we'll get to this later with the awake thing, but for me, when I have somebody who has hypoxemia and their rate limiting step is shunt and FRC and whatnot, I personally consider BiPAP and high flow to be fairly equivalent.
I mean, that's great. A great overview, and I think does a great job of touching on several elements that we don't necessarily unpack in the moment. I think it's funny that perhaps for the first time on our podcast, it's an emergency medicine trained physician that mentions FRC amongst two pulmonologists. I'm not sure if the term FRC has been mentioned yet. And I love that you brought it up because to your point, Jarrod, like it's not hard to imagine a patient who suffers from obesity has perhaps been on some anxiolysis, is supine, and maybe has pulmonary disease in your ICU. I mean, that's probably a big chunk of your ICU. Pre-intubation, if you use things like ketamine or other agents, even Precedex, things that are going to try to anxiolyze, that could potentially contribute to increases in FRC, minimally, but potentially, among those other things that I brought up. And so I think it's really important to be mindful of all that, in the way that you sort of outlined it. So thanks for bringing that up.
Oh yeah, thank you.
So to sort of bottom line what you said there, so you need the ideal method is going to give you an adequate FRC. So if you've got a bunch of de-recruited lung to help you recruit it, hence non-invasive having an advantage, it's going to provide good denitrogenation. So you need lots of oxygen to displace nitrogen. And then ideally something which is, not going to fail because of a lot of shunt, which admittedly there's less we can do about.
Yes. And if you're looking for one thing, I mean, I don't subscribe to this, but if you want one thing to use for everybody that you're going to RSI, it probably would be BiPAP. I think there's limitations to BiPAP that we can talk about when we get into the awake thing. I personally, let's say I had somebody on high flow, they're on 60 and 100. I wouldn't switch them to BiPAP and then induce them. I would keep them on. That Florali 2 trial that was done that looked at it, really, there was no significant difference in moderate to severe hypoxemia until they got to like second or third order statistics. And just as a spoiler for the awake thing, still 25% of those patients who are on BiPAP still desaturated. I think that's too many.
Right. I think that's a great point. Yeah, I think this is a good example of like perfection's the enemy of the good, or maybe just that there's like limited square footage in these rooms.
Yeah.
So you can't bring in your ventilator, bring in your non-invasive, and bring in your high flow and expect to still have people in the room.
Right. Or enough oxygen sources.
Right. That's right. Too. Yeah. Actually, that's actually in many cases the more critical one. Right. You only have so many plugs on the wall, so you're like dynamically swapping them. Yeah.
I know when Scott Weingart and Rich Levitan started talking about putting just low flow nasal cannula on for every intubation, it was an oxygen source problem. We were having to, I was an EM resident at the time and then a fellow, we're having to use the transport tanks and
Yeah,
whatnot.
exactly. You need the tank at the foot of the bed in order to power the cannula, and then you have the mask and the BVM at the head of the bed. Yeah.
Most modern hospitals now at least have like 4 oxygen supply, oxygen ports in the ICUs, but it's not always the case.
We're actually in the midst of building a new hospital where I work, and we keep telling them like, you got to plan for the future. You got to have more oxygen ports. You got to have more suction ports, and the architects are like, nobody needs more than 2 suctions. Like, oh please.
Yeah, not just that, you need enough room for the ECMO circuit and the CRRT
Right.
machine and all this.
Yeah, they don't, those things they're getting smaller, but they're not that small.
Right.
Yeah, so I think, because I know we have a lot of other topics we want to get to. But I think, at least from my standpoint, Jarrod, it's a very kind of practical and pragmatic approach for our listeners. It's like, okay, well, if you have to have an algorithm, if you have to pick one thing, generally speaking, your bi-level non-invasive is going to achieve most goals in most cases, which again, I think that's very practical. I think outside of that, different patients, I think of it as like, how much runway does that patient have? And so like, your healthier patients, maybe if you're working in a trauma ICU and you're intubating them for issues that have nothing to do with pulmonary disease, yeah, they come into the ICU with a lot more runway than someone who is, let's say, suffers from morbid obesity and has ARDS with underlying lung disease to boot. Clearly, like, you can almost do, and correct me if I'm wrong here, within the confines of appropriate practice, you can almost do whatever it is you want to do in the first case. Whereas in the second case, you have to be, I think, very particular about how you pre-oxygenate. And those are great cases, I think, for non-invasives especially.
Yeah, for sure. I mean, everything's a bell curve, right? And depending on what your
Yeah.
profile of patients are, your bell curve may be skewed left or right. But I think if you're starting off and they're on nothing and they have no airspace disease, a flush rate non-rebreather is fine. If you want to use BiPAP for all those cases, I think it's probably unnecessary, but it will give you everything that you need in most of those patients. But as you start getting into pneumonia, acute lung injury, ARDS, I mean, that's where you're pushing into the physiologic difficulty, and it needs to be a little bit more thoughtful.
Awesome. So, Nick, are you okay with us moving on to the next topic?
Let's do it.
What do you think? So,
controversy number 2.
Controversy number 2, yeah. So, which may or may not be a huge controversy. Let's see. So, here's the question: is succinylcholine really the agent of choice as far as neuromuscular blockade goes in RSI?
One word answer is okay.
My diplomatic answer is it in the emergency department is probably fine. Although I don't like it. I think my personal opinion is I think it belongs in the History of Medicine Museum.
Nice. So you're in good company with that.
Let's unpack that a little bit more though, because we've talked about this on the show before, but I'd love to hear your take on why because presumably you're using rock instead of sucks, right?
Yes. Yep.
And so why would you ever want to use a drug that has slower onset? Isn't it worse? I'll just try to steel man the argument here.
And maybe, Jarrod, you could also flesh out that dichotomy between why you think it's probably fine in the ER versus maybe in the ICU not so fine.
Yeah. Okay. Nick, to your question, I think one of the problems with sucks is, the hyperkalemia thing and all that. And we have so many patients that come back from an LTAC or a sniff, something like that. And their risk of myopathy and hyperkalemia is significantly high. Okay. Number 2, the patients with respiratory failure from hypoxemia, pneumonia, and all that stuff. Many of those people have high inspiratory effort, and we want that to go away once they end up on a ventilator anyway. And the rock gives us a longer runway. In terms of onset time, that's dose dependent. And so if you look in the literature, there's doses all over the map. But if you If you give 0.6 per kilo, yeah, it's going to take longer. If you give closer to 1.2, in the book, we put 1.5 to just make it the same as sucks. But if you give above 1.2, your onset time will be nearly the exact same.
I think that's a crucial point, that sometimes when people have this idea that sucks is faster, it's faster than a too low dose of rock.
Correct. Yes.
One argument I hear sometimes that I want to ask you about too is this idea that, but the onset, the duration is too long.
Yeah.
Right. This idea that, like, if there's a problem with sucks, it'll just wear off and they'll be okay and they'll go home.
So
right.
We've all seen that graph of the desaturation curves. It's like child, obese person, critically ill person. That paper by Benioff was a mathematical model.
Yes.
To answer this exact argument, right? And that argument was, I'll just let sucks wear off and let them start breathing again. And the Benioffs who wrote that, their conclusion was that that's a foolish plan because they're going to end up with anoxic brain injury by the time they spontaneously breathe.
They'll have been dead for a few minutes by the time
exactly.
it wears off. Yeah.
I think the modern corollary to that is the Sugamidex argument with rock. That, I'll just reverse it with Sugamidex. But to find the Sugamidex, drop enough Sugamidex, give it, wait 3 minutes. It's the same thing. They'll be brain dead by then.
Yeah.
So maybe don't approach your intubation with the mindset of like, I'm just going to let this wear off, or I'm just going to reverse this. Like, maybe approach it with the mindset of like, I can
leave. Yeah.
Yeah. It's like, maybe like approach it with the mindset of like, I'm going to establish an airway.
That's right. Yeah. I'm committed. And if my plan fails, I'm down the rescue oxygenation path.
Exactly. I love that.
It's really interesting to me. I'll get to your question in a second, Cyrus, but it's really interesting to me to see what's happened since I started teaching the airway course. So we started doing the critical care course in 2015, 2016, something like that. And I ask everybody at every course, how many of you use a paralytic? And in the first courses, almost nobody, because they weren't allowed. And it was always the same argument. What if I can't bag? What if I can't bag? Now it's completely the other way. Everyone's using paralytics. And I think the literature has kind of put that to bed in terms of what's most likely to be successful. It's to use a paralytic. And the other is that if you can't bag, a paralytic will improve your ability to bag too. So I think that fear is kind of resolved. To your question, Cyrus, the reason I still don't like sucks in the emergency department, if I remember the NAP6 data correctly, and I might have to fact check me on this, but if I remember it correctly, there was more anaphylaxis with sucks than any of the other paralytics. So that's another reason not to use it, but fact check me on that. In the emergency department, there's such a historical use of succinylcholine in terms of, most of their intubations are likely to be for airway protection, obstructing pathology, whatnot, where, people who had respiratory failure, many of them now go on some non-invasive and then come to us. I think sucks is probably more okay because their patients aren't really coming from LTACs as often as ours are, that kind of thing. I still don't like it. Still think we should just all move to rock, but it's probably more okay.
Yeah, I think so. Fact check. Succinylcholine induced anaphylaxis was twofold more likely than other neuromuscular blocking agents.
Okay. Yeah.
So double your risk.
And it's this idea of like, I think as an intensivist, the deck is often already stacked against you by virtue of the patient's presentation.
Yeah.
There's not really any reason to continue to slide aces across the table, and make your life even harder.
Yeah, exactly.
So that's, I think that's a great, great discussion there. And I think, again, I'm glad you brought that perspective, and we touched a little on the emergency department. So I think I would agree. I think sucks probably does belong in the History of Medicine Museum. As you said, there are some cases where it makes, and I don't even know if I'd say it makes sense. There are some cases where I think it's a reasonably fine choice, but in our line of work, I don't like to roll the dice.
Yeah.
Actually, moving just a little bit orthogonal on this, just because, I think we could take a minute here. What are your thoughts on pre-hospital? Because I think that's a place where sucks is still being used. And I always kind of recoil at that because I'm like, you don't know this person's potassium. Like you
Yeah.
might be
Yeah.
meeting somebody without any context. Like that to me seems like a situation where the advantages of rock would be even better, especially since like they presumably want the person to not be moving the entire way to the hospital as opposed to having it wear off part way. I'm curious your thoughts on that, Jarrod.
Well, there was a trial in this. I think it was published in JAMA. And they looked at Sucks versus Rock in the pre-hospital setting. There was no difference.
Right.
Um, RSI in the pre-hospital setting is a totally different discussion that we could spend a
Fair.
whole other hour on. But I think what drugs they use in the pre-hospital setting is probably the more driven by the biases of their medical director writing the orders
Mm.
than anything else.
Fair. Okay. We'll jump over that landmine for now and move on to the next controversy, which I think is going to be a good one.
Yeah.
So, I think there's kind of this ongoing debate in the critical care field right now between two drugs for what is the induction agent of choice, etomidate versus ketamine. And just to sort of lay out some foundation here, they're both widely used. I think there was an argument years ago, and correct me if I'm wrong on this, that etomidate was more hemodynamically neutral. And then there's some more recent data that suggests that maybe that's not true. And furthermore, there may be higher mortality when etomidate is chosen compared to ketamine. And I guess there's also this sort of related sort of wooden pearl slash myth, or maybe truth, which is that etomidate causes adrenal insufficiency, and maybe that's a reason for it causing more mortality. I'm curious to get your reaction to all of that and kind of tell us where you come down on this story.
Yeah. Um, okay, this could be fun. So the etomidate thing, I talk a lot about this in the book actually, about the multifacets of this, but they used to use continuous infusion etomidate, I think in the UK, for sedation, and a lot of those patients were dying from refractory shock, adrenal insufficiency, and whatnot. That's where that came from. So then move forward to does it
So,
does
so
it
a much higher dose
yeah,
than
for
the
longer
dose
too,
used.
yeah.
Yeah, yeah,
So does a single dose of it make a difference, given that it does block the terminal enzyme in cortisol synthesis? And that takes hours, right? That's not a peri-intubation thing. That takes hours. So in terms of the hemodynamics, there was one study that I know of where that it maybe reduces effective arterial elastance some. But all drugs, even the hemodynamically neutral ones, will cause some hemodynamic consequence, even just from the effect of turning the lights off and making people unconscious, right? So
right.
of hemodynamically stable drugs, etomidate is a hemodynamically stable drug. So is ketamine, for example. Now, there were a couple other things that happened. A hurricane hits Puerto Rico and wipes out the production facility for etomidate. People start talking about the risk of adrenal insufficiency and sepsis and whatnot. And then, oh, by the way, we also have this other drug, ketamine, that is a indirect pressor and whatnot. So let's bring in the ketamine thing. So ketamine, by its NMDA action, is an indirect sympathomimetic. So if someone is naive, let's say, give you ketamine, your cardiac output should go up, your blood pressure go up. But if you're maximally adrenally squeezed and you're vasoplegic, it's also a direct myocardial depressant. And so you may get all of that, and then all you get is the myocardial depression effect of it, and they may arrest from that, right? But that's also an indirect effect of the drug, a secondary effect of the drug. But the argument was because it's a sympathomimetic, maybe there's this adrenal insufficiency thing with etomidate. Let's just all use ketamine. And then it kind of turned into, are you a Coke person or a Pepsi person? Right.
I like it.
And people have been studying this forever. I mean, if you just go to PubMed and you go down this rabbit hole, there's been the first randomized control trial that I know of was in 2009 in France by Javert. There was no difference.
Right.
And then there's lots of observational stuff that maybe there's a little whiff of improvement with etomidate, and there's a little whiff with ketamine. And then gasoline kind of got poured onto this fire a few years ago with a couple of publications. One was that meta-analysis out of, I think, South Korea. And interestingly, 2 weeks before that came out, that was also the same group that published a meta-analysis saying we were killing people in the ICU by sedating them with propofol after intubation. So they published their meta-analysis on etomidate versus ketamine, and they showed a higher probability of death with etomidate. I'll come back to that in a second. The second was the Match It trial. So the Match It trial was out of Texas, and they all of their ICU intubations were done by their anesthesia group, and they had a QI registry. In their QI registry, they looked at it and they showed a higher 7-day mortality with etomidate than with ketamine, and so they powered their randomized control trial for that. And their hypothesis was that ketamine was more hemodynamically neutral, and so their exploratory outcomes were on the hemodynamics. And so they run this randomized control trial, and they show indeed there's a higher 7-day mortality with etomidate than ketamine, but that's no outcome in any trial is 7-day mortality, right? That's kind of an
Yeah, right.
unusual outcome. And so if you look at 28-day mortality, it was the exact same. And their exploratory outcomes on the hemodynamics all trended worse with ketamine. And so
Hmm.
that matcha trial was the major driver for that meta-analysis. And the meta-analysis used the primary outcome of the trial, not standardized 28 days. So if you rerun the stats to 28 days, there's no difference. Since that time, there's been a few other RCTs. Brian did one at Hennepin, showed no difference. There was one in Scientific Reports, no difference. And then there's been a couple other meta-analyses. There was one this year in April by Bram Rockwerg and his group from Toronto, and they actually showed the opposite, that there's a higher probability of benefit with etomidate. My sort of take on this is that we're barking up the wrong tree. They're both great drugs. They both have their consequences. Relying on the indirect or secondary effects of a drug to either make a patient worse or make a patient better from their primary hemodynamic problem, I think is a fool's wish, right? And I think as intensivists, we need to move that conversation forward to how do we better characterize our patients in terms of risk? How do we modify that risk with resuscitation and what?
So what I'm hearing here is, as long as we're not using big doses of propofol to induce people, we're doing something right. That Coke or Pepsi are both valid choices. Don't use, whatever, like Shasta off-brand
I was going to say
propofol
Shasta.
represents.
Yeah, Nate Schmishny from Mayo has some interesting stuff on propofol, right? So he did some hemodynamic stuff, and propofol actually it's also a negative inotrope, but because it drops your SVR so much, your overall cardiac output goes up. And so, but the difference between propofol and these other drugs is that propofol is a direct vasodilator. It is not an
Right.
indirect anything. It is a direct vasodilator. And so of all of the drugs that we use for induction, propofol is the one that most consistently shows we should not be using that at induction doses for routine RSI.
I'll share my perspective, and I'm
Yeah.
curious, Jarrod. So I don't use a lot of etomidate. I've used it a time or two here and there, and I've kind of even gotten away from using just ketamine because a lot of times I do see this like transient catecholamine release kind of resulting in this big old hypertensive event, and you're like trying to manage. I'm a big fan of the kind of ketofol approach where I'll give them like a combination of ketamine and propofol, like roughly 50-50. And I have had tremendous success with that. I don't know if that's something that you've seen done to achieve both, that relative hemodynamic neutrality while mitigating some of these theoretical or somewhat founded concerns. That's at least my approach. It's worked well for me.
Well, I think it's great, right? I mean, you're trying to use the drugs the way you're trying to benefit, use the benefit of the drugs based on the patient's
Trying.
like physiology. Yeah, the ketofol was a huge thing when I was doing emergency medicine, especially as a resident. And the thought was, I'll mix them in the same syringe, and you get the benefits of both. But sometimes you get the cons of both too, right?
Sure.
Right. Double the side effects.
Yeah, exactly. So I also occasionally will use propofol, but when you start tinkering, like giving a little bit of propofol until they're asleep, then giving the paralytic, or giving a little propofol, then giving a little ketamine, all that stuff, that's not traditional RSI. That's
Sure.
modified RSI. So I think all that stuff's awesome. But in the context of single induction dose of a drug, I think we probably, I don't think a trial is ever going to show a definitive answer.
And I think you hit some really important kind of like meta points, I would say, like about the limitation of meta analyses. Like they're only as good as the trials that are in them. If there's significant heterogeneity or there's one giant trial, you're basically just, citing that trial. And then, like you said, I mean, if you're mixing and matching different primary endpoints, or another one that I kind of hate is when there's a trial that's stopped early, either because of benefit or harm, but then it has a smaller effect on the meta-analysis because it has fewer people. And like just these are just like limitations, right? Like, and sometimes I think we sort of look to the meta-analysis to answer all our questions, and it can only tell us what the trials in it tell us, and it's only as good as the worst trial that you include.
Yeah. I mean, look, what do we want? We don't want our patients who are normotensive to become hypotensive, and we don't want our hypotensive patients to code. And I just think neither, I think etamidate's not going to make that worse, and ketamine's unlikely to routinely make that better. And so I think this is an area in airway management where people really, it's kind of like Coke and Pepsi. Clearly, Coke's better. We all think Coke's better, but
Yes, agreed.
the blind taste tests would suggest that people can't actually tell the difference. And
Well,
so
those people are not very smart.
yeah, I kind of facetiously joke about how we talk about ketamine like the lay population talks about CBD oil, that it just cures
Mm.
everything.
That is a fair criticism, I think. Yeah, very true. And TXA, I'm not sure what that is in that analogy, but
Oh,
that's
no.
like some other, wellness influencer thing that we
Yeah.
think fixes every problem.
TXA is another perfect example where we just have this strong belief and we throw it at everything that bleeds, that just continues to bleed.
Well, again, another great discussion. Why don't we take a quick break and we'll get right back to the rest of our controversies.
Okay, before we move on, we are proud to announce that this episode of Critical Care Time is sponsored by the Difficult Airway Course.
The Difficult Airway Course, Critical Care, is the premier airway management course designed specifically for critical care physicians and APPs by practicing airway experts who understand the unique challenges of managing airways in the ICU.
This includes deep dives into topics including anatomically and physiologically difficult airways, rapid sequence intubation, awake intubation, surgical airway techniques, airway ultrasound, high-risk extubations, and more.
Now, you won't just be watching folks manage airways. This course provides hands-on, evidence-based, immersive training with code airway stations designed to prepare you for a wide range of situations you're likely to encounter.
Plus, the Difficult Airway Course is taught by world-renowned airway experts who share the tips and tricks they've picked up over many years on the front lines.
Now, you may be wondering when you could participate in such a course.
I was just wondering when I can participate in such a course.
Well, Nick, as luck would have it, there's a course being held at the Manchester Grand Hyatt in sunny San Diego, California from November 14th to the 16th.
Get excited.
And when you register, your tuition not only includes entry to the course, but a copy of the new textbook, Manual of Airway Management in Critical Care.
Plus, since, if you're hearing our voices, you must be a Critical Care Time listener, you are entitled to a special discount. Use discount code CCTime25 at checkout and save $250.
You can find all the details you need at www.theairwaysite.com/critical-care.
Gain the confidence and competence to manage the most complex airway cases, even when the pressure is on. Because when it comes to airway management, there is no such thing as being over-prepared.
And now, let's get back to the show.
Let me give a little pushback on this, which is, the way I think about etomidate versus ketamine is a little bit of a pay now, pay later thing. Whether you believe this adrenal insufficiency thing or not, and I think you've given a good reason not to believe it. I think, the theoretical badness of etomidate maybe comes a little later. Whereas, so I wonder if, in an era where we're using steroids more freely in people who are in shock, if that even really matters on one hand. Like, have we unknowingly fixed the problem because we're solving a different problem? Well, let me get your reaction to that, and then I'll argue about something else.
I have two reactions to that. One, when we did the SCCM airway guidelines, we looked at this. Does the biochemical reduction in cortisol lead to a clinical adrenal insufficiency syndrome. And we didn't find that to be the case. And the other is exactly what you're saying, right? Now we're giving every community-acquired pneumonia patient steroids. Everybody in shock gets steroids. I'm not sure that it actually makes much of a difference.
Fair. Okay. I guess my second point is that, is this something where it doesn't really matter Coke or Pepsi, but this is just another decision that is adding to decision fatigue and making intubations harder. Like, as in, even though it doesn't maybe it doesn't matter a huge amount, should we standardize, like, in our practice? Like, should we try to avoid the issue of trying to decide every time Coke or Pepsi, and just say, like, hey, in my ICU, we're always going to use Pepsi. We're always going to use Coke.
Mm-hmm. I assume for you, it would be ketamine.
Yes, correct.
Yeah. For me, it would be etomidate.
Oh, interesting. Okay.
Yeah.
Why have you come down on that side? I'm curious.
Oh, I've seen throughout the years in the vacillation of standard practice where it's like, okay, we're all going to use ketamine. They said it's the new hot thing or whatever. I've seen far more people code from an RSI dose of ketamine than I ever have with etomidate. Now, that is obviously a heuristic, biased interpretation of my clinical experience. But for me, I just don't see any downside to etomidate. And I see potential real peri-intubation downsides to ketamine.
Interesting. Okay. I guess if I'm gonna steel man this, I think the two best arguments that I sort of see, at least in my shop, in favor of etomidate are, number one, because it's not locked up the same way. It's faster to get. Like, it's in the intubation drug med, so it's faster, so it shaves a couple of minutes, which seems valid. When you want it, great. The other argument that I think makes sense for it is it lasts a little longer. Okay, Nick from the future here, traveling back in time to correct a little error, set right a thing that once went wrong. I want to clarify that ketamine has a longer half-life than etomidate. This is important because etomidate's half-life is really short, so the combination of etomidate plus rock, the etomidate will wear off before the rock. Just to clarify what was said, ketamine, longer half-life than etomidate. Etomidate has a short half-life.
I think that's a systems problem in that if you're going to give anything plus rock, you need to make sure that you have sufficient sedation on board immediately after the tube goes in, then you have sufficient sedation. I think it's a systems problem.
It's a planning problem.
Right. You can't be like, we're doing such a bad job with our sedation practices that I have to make a different choice with my induction practice.
Yeah, exactly.
It's an unreasonable expectation.
Yeah.
I don't know, man. I feel like you've turned me on a little bit more to etomidate, if I'm being honest, but and maybe this is just, I'm waiting for that shoe to drop, but I've had such good success in my practice with the ketamine propofol combination that I recognize that it does complicate things a little bit. And I love the point about, like, but you can get etomidate like super quickly. But I don't know. I think in my mind, it's like, if I'm going to the floor, I'm intubating someone on the floor, and I know very little about them, and I probably need to be expeditious about it, then it's video laryngoscope, etomidate, rock.
Mm-hmm.
If it's in my ICU and I know a little bit about the patient, or if I've just had an opportunity to, like, even just check out the chart, I've had good enough success with that combination of ketamine and propofol that I like it. And then the other nice thing I find is that my approach, which is, again, just my approach, is as the dust is settling, kind of in the first 6 to 8 hours post intubation, I like to use propofol to sort of like bridge that period of time as I'm trying to do my procedures and whatever else I need to do. And so if I'm using propofol as part of my induction, I kind of already have it there too, and it's easy to just hang and get going. So that, but like using straight up propofol in the medical ICU to induce a patient, I think you're just asking for trouble.
Yeah, we're talking about two different things, right? So
exactly. Yeah. I want to make abundantly clear that I'm not just like giving everyone 250 milligrams of propofol and being like, yeah, YOLO, let's go. Let's see what happens.
I also use propofol. Let's say you've got the GI bleeder that you're trying to resuscitate. You can't keep up, right? And you're trying to intubate them. Sometimes I will give them a tiny little dose of propofol, 10 milligrams at a time, until they're asleep. And that may take a minute or two till you've given them enough to where they're asleep, and then give the paralytic. That's not RSI.
That's true.
Sense,
That's very true.
Can I ask you guys a question?
Yeah.
You must use ketamine if you're going to intubate an asthmatic.
Oh, huh.
Mm,
It sounds good. It briefs well. So the reason you're asking that question is that we do know that ketamine has, of course, bronchodilatory properties. The flip side of that is ketamine tends to cause bronchorrhea as well, which is suboptimal. And the other thing I'll say, and Nick, I'm curious to get your point here or your opinion here. Like, it's very rare, if ever, that I'm intubating an asthmatic who has not already gotten all of the bronchodilators.
Yes.
Like, am I really going to glean like a tremendous benefit? Now, for maintenance of sedation, yeah, sprinkle a little ketamine in there. Maybe that's going to help. I don't know. I mean, maybe I haven't seen the data. I haven't done the study, but I think that it's a bit of a silly argument. I don't know, Nick. What do you think?
no, I agree with what you just said. I think that if you're upfront intubating a lot of asthmatics, this might be a consequential difference. But if you're doing that, you're doing a bunch of stuff wrong. So
Right.
I agree. It
Like, why are you doing that?
doesn't make a huge difference. I mean, I guess one interesting question though is, and we're going to talk about awake intubations in a second. So maybe save some of this discussion for there. But one of the advantages and one of the things that I like about ketamine is that you can dose it such that the person is still kind of awake, calm.
Mm-hmm.
And, let's say you have an asthmatic who you're trying to support with non-invasive ventilation. Ketamine can be a great adjunct there. And so I kind of feel like if you've already gotten it out to use in this sort of pre-intubation, sort of awake state, why not keep using it? Should you
Right.
mix and match?
But
They're getting 80 milligrams now. Let's give them 200 more.
Yeah, exactly. We've already broken the bottle open.
Yeah. To Jarrod's point, which he's made a few times, and it's a good one. Like, now we're talking about uber delayed intubation. We're kind of getting further and further away from that idea of RSI. So I do think we have to recognize like it's an apples and oranges versus apples to apples.
The reason I bring this up, this has wormed its way into textbook canon. And it's on the, we were chatting earlier before we started recording about the ABIM MOC. It was one of those questions too. And I, Cyrus, I agree with you. The exact word I use for it is I think it's silly. I mean, no asthmatic has ever become magically easy to manage on a ventilator because they got ketamine with their intubation.
No. When they get magically easier to take care of, it's because they didn't have asthma in the first place and you're treating their vocal cord dysfunction.
Yeah.
And now all of a sudden everything's fixed. It's not the ketamine. It's just the mechanics of it.
Right. Did you try telling them to stop?
Yes. So that was a very fun discussion. Any other points before we move on, guys? Because I know we have another couple controversies to get to.
Nope, let's get to it.
Cool. All right. So let's take a quick break for our audience, and then we'll roll right back with a few more controversies.
Yeah. Well, Cyrus, you mentioned something in your last answer talking about VL or video laryngoscopy. I think this is a great sort of controversy to steer into with our discussion. So I'll just phrase it this way: should video laryngoscopy be the first line intubation device used in most or all ICU intubations?
My short answer is yes.
Yeah.
My clarification is that the blade geometry matters, right? So
Yep.
So the original video laryngoscopes were hyperangulated blades.
Yes.
And
D blade,
was,
if you will.
Yeah, it was the GlideScope blade. It was 60 degrees. Then Storz came out with the D blade. And that's meant to be a difficult airway blade. Right. And then the answer to that, the phenomenon that you saw was that made difficult airways easier, but it made easy airways more difficult. And so all the manufacturers started making standard geometry Macintosh type blades. And so for routine intubation without predicted difficulty, I think standard geometry should be the go. If you have predicted difficulty that you're still going to induce and put to sleep, then it should be a hyperangulated blade.
So you are in safe company with this opinion. I think Cyrus and I are firmly on Team VL. But let me just steelman this one for a second here and kind of give you kind of what maybe some other people say. So I guess one argument I hear in favor of DL is it's been studied. There's no difference. People will talk about like the Fellow trial that found no difference in first pass success, or the MacMan trial, the French multicenter ICU trial, where they found no difference in first pass success and more life-threatening complications with VL. What do you say to those people?
Okay. I have a good argument for that. So, interestingly, the poison pill in those early trials is that the opt out, the person with a history of difficult or suspected difficult airway, they were excluded.
And they all got VL anyway.
They all got VL anyway, right? And so
Yeah.
if you exclude people where the device is meant to help, and you only include people where there's either going to be no difference, or in the case of hyperangulated blade, maybe a little bit more difficult, you're going to conclude false equivalence, or you're going to show deals better. In that MacMan trial in France, I mean, there's a whole host of problems with that, but the main one is that they didn't use stylets.
Right, which is kind of wild to me.
Yeah, you're going down the midline, no stylet. Of course, you're going to show no difference. But since then, I mean, this is, to me, this is settled, because there's been a whole host of randomized controlled trials that have shown, first of all, DL, I don't think, if you fact check me on this, but has never actually shown to be superior. VL's always at least as good, most of the time better. And now there's RCTs in the operating room, and so then there's the age. People have this emotional attachment to their favorite laryngoscope, and the argument is, well, it's better if you suck at airways, right? But I'm an expert, therefore I'm just good. Turns out, if you actually look at that Cochrane review, and there's also a systematic review in critical care medicine, if you actually dive into those details, the biggest benefit was in experts. And then I think it's in anesthesia.
And by the way, as a quick aside, the definition of expert here, I think, is kind of an interesting one. Like,
it's a specialty.
Yeah. Well, it's also a very relatively low bar, right? I mean, like, some of these trials used like first year fellows performing their first intubations
Right.
as like the target intubator. And that's obviously a very different population than your typical intubator. But some of them defined expert as like, I've been doing this for more than 3 years, which, kind of depends what you've been doing for those 3 years.
Exactly. There's just, I mean, I'll get to this point in a second, but all the non-laryngoscopic benefits of VL, shared mental model, all that stuff, all of that just adds to it's the cream on the top.
Yep.
But there's a meta-analysis, sort of an ongoing living meta-analysis that was published in, I can't remember if it was anesthesia or anesthesia and analgesia, where they've looked at the Z-score over time. And what they found is that it's approaching closer and closer to definitive, where it is definitively better, and it needs to stop being studied.
Right. The more we study this, the clearer the answer becomes. Right. And I just want to give our listeners kind of maybe the trial that I think is maybe the most important one here to read, which is the device trial, which found higher first pass success with VL compared to DL and similar complications. And this trial was like bigger than all the prior RCTs combined. So it really should drive our opinion.
Yeah. I just talk about the trial for a second? So the pragmatic trial design, the way in which they do these, there's some limitations to that, right? If you have a complex intervention like airway management, where there's so many variables that contribute to the success or failure of it, and you don't control any of those other ones, the one that you're studying needs to have a Leviathan effect on the outcome, which is why most of those trials have shown no benefit, right? Abnegation, positioning, all this other stuff. But the DL versus VL one was clear.
Right. It was stopped early for efficacy, in fact.
Yes, exactly. Which means if you're going to do one thing to improve airway management, just one thing, who cares what drug you use, all this other stuff, one thing, it would be use VL.
All right. Well, let me steel man another argument I hear sometimes, which is these machines are expensive. We don't have them everywhere. Whereas if I go to a floor code, I need to be ready to intubate with DL. And if I'm using this fancy gizmo all the time, like my skills will fail me when I go to do that. What's your take on that?
Well, to the latter part, there's been evidence that shows actually if you get good at VL, you can keep your skills at DL as well, because
it's if you're using a standard geometry blade,
correct,
it's the same skill,
and you get a panoramic view of the airway. You kind of understand the anatomy more, where you are and whatnot. To the former point, I think I mean, I hear this all the time. The argument used to be, what if I go to a place that doesn't have VL? And that's when they were $60,000, right? And now you can buy a very good, very portable video laryngoscope for like $1,500. And so if your institution isn't supplying the portable version, if you're a Verathon institution and you don't have the GlideScope Go, Storts has one for the CMAC, or if you don't have a King Vision or a McGrath, that kind of stuff, I would just buy one myself. I mean, I would not go to the floor and RSI somebody, right? I would bring them back and do it with my video laryngoscope. But I really think, I don't even know how many times that happens nowadays where people don't have a video laryngoscope.
Yeah, I think it's a largely theoretical concern. And maybe it's like like you said, valid concern years ago, and now it's like they're pretty ubiquitous.
Maybe developing countries, but I think if you work in the United States and you don't have one, that's a voluntary low resource, not a real low resource environment.
And as you said, I mean, I think, this is something where you don't, like there's an argument for a health system not to put a McGrath in every single code cart. I get that. But it doesn't mean that you can't ensure that there is one at every single code. Those are two
Right.
separate things.
Yep, absolutely.
All right. Another sort of related question. Default hyperangulated or standard geometry, and why?
I wouldn't default either. I think there are people who default hyperangulated, and then their backup is standard geometry. If you do that, you're hoping that difficulty with a hyperangulated is the bug in the design, not a feature of that patient's airway. Right. So
Right.
I think if you don't predict difficulty, it should be default standard. If you do predict difficulty, it should be default hyperangulated.
Exactly. Okay. One more argument that I'll steel man here, which is, what if just one drop of blood or vomit gets on the camera? Why isn't this thing now useless?
This is like, in my mind, this is like the don't go swimming within an hour after you eat lunch, or don't go outside when it rains, you might get pneumonia. I mean, this just, somebody made this up at some point, because yes, if you have a pharynx full of blood or vomit and you plow the laryngoscope through it, you're not gonna be able to see. But there's been 2 studies on this. We did one here. We looked at the soiled airway, and what we showed was that you reduce your first pass success by about 10% for each of those devices. So the delta still favors VL. There was another paper out of the NEAR registry that showed same thing. VL still mathematically better, not statistically better, but still equivalent. I think you have to, it's how you use it. If
Yep.
you induce them and you compress the tongue as you go down and stay above it, you'll be fine. If you want to follow the curvature of the blade along the curvature of the hard and soft pellet, yeah, you're probably going to plow through that.
Right. If you dive into the vomit, you're
Exactly.
covered in vomit. Yeah.
If you induce them and they're exsanguinating, well, you're limited to putting in a supraglottic airway anyway. You're not going to see that airway no matter what you use.
Right. And by the way, if you have VL and you lead with suction, you can keep it dry, hopefully, even in that extreme case.
Jim Ducanto has done a ton of work on this and revolutionized real-time decontamination of the airway if you're using VL. And I think it's phenomenal. The number of times that you're actually going to see someone with that much vomitus or blood is going to be very few, right?
Right. Yeah, and that's a great device that they have too. That particular suction catheter is very effective.
Yeah.
And it's funny, I was just kind of ruminating over one of your points, Jarrod, which is like this: we just need to stop studying this because there's not, And then it's like in January of 2025 in chest, there was video versus direct laryngoscopy for tracheal intubation after cardiac arrest, which was a secondary analysis from device, I believe. But shockingly, it shows that in cardiac arrest, we should also be using video laryngoscopy. Yeah. So it's like, it's starting to feel like a low hanging fruit publication. And I'm just kind of like, can we move on?
Yeah.
But Nick, you had one other point you want to make.
I was going to say one more point, which I think is maybe a benefit that you mentioned that I want to just emphasize a little bit more for our listeners, which is that 2 of the sort of extra benefits of VL that you get are you get the ability to record every intubation. So you get this QI, QA capability, which I think is really important and potentially maybe a credentialing tool in the future. And then secondarily, especially when you have multiple intubators present, you get the shared mental model. The person, you see what was hard, so your second attempts can be better.
Yeah.
Like I wouldn't let a trainee intubate without VL, because like maybe I'm just not trusting enough. But like I need to see what they're seeing.
Yep.
Yeah, I grew up learning DL with the attending standing over me saying, "What do you see? What do you see? What do you see? What do you see?" That's clearly
They're
not
like right over your shoulder, and they still can't see what you see.
Yeah.
Right? They're like a parrot on your shoulder, and they're like, "What do you see?"
So Gabe Wardy, he's EM critical care at UCSD, and he does their airway stuff there. And they had a project where they recorded, GlideScope automatically records sometimes. You can set it up to do that.
Yep.
And
you should.
And they had a curriculum for their fellows, and what made the biggest improvement in their curriculum, and it was reviewing as a group the videos. I don't see any reason why not to leverage that capability.
Absolutely. No, I think that's something that moving forward, like, if you want to make this procedure as safe as possible, you need to review every intubation and try to identify opportunities for improvement every time. Awesome. Okay. Cyrus, any other closing thoughts on this one? This was a fun one.
I think we've done our due diligence here and really, hopefully put this discussion to bed.
So bottom line, use VL. If you don't have VL, you should buy VL with your own hard-earned cash. And there's really no excuse in 2025 for not using VL primarily.
I agree. I think it's a medical legal thing, actually. If you have VL available and you choose not to use it and you have a bad outcome, you might be liable.
That's a great point.
Absolutely a great discussion, I think, on that VL versus DL. Hopefully we've put that now to bed. I think maybe we should probably move on, because I know there are some additional controversies we want to cover. And Nick, there was one in particular that you were passionate about unpacking.
Oh, there's many that I'm passionate about, but this is the next one. So we've done pre-oxygenation, we've done meds, we've done which device do you reach for. Now you can see the cords. What do you do next? And so the question I'm getting at here is, should we routinely be using a bougie on the first attempt? And this is one where there seem to be some very strong feelings and maybe a relative dearth of hard data. Jarrod, I'm curious what your thoughts are on this. Should we use a bougie on the first attempt?
If you're using a hyperangulated VL, no. If you're using a standard geometry VL or DL, yes. And the literature on this is interesting, and it kind of supports what I was mentioning earlier about the limitations of the pragmatic design. So Brian Driver is the primary author for both of these trials, right? The first one at Hennepin County, I think it was BEAM was the name of it.
The bougie use in emergency airway management. Excellent acronym. Turn that into BEAM. Nice job.
Exactly.
Guys.
Yeah. And they showed it was like 98% first attempt success if they used VL and a bougie as opposed to
96 versus 82. Absolutely.
Yeah,
It was a clear
phenomenal, right? And then the pragmatic group decides to replicate this across all their centers, and they showed no difference, and everything plummeted. But so how do you square that circle? I'm going to be so good at one place and then no good at every other place. And to me, I think this is an example of what I was talking about controlling all the other variables. At Hennepin, they intubate everyone the same way. They are positioned the same way. They are pre-oxygenated the same way. Everything is the same. And so the only variable that's different there is it a stylated tube or a bougie? In the pragmatic trial, it was sort of, you can position how you want, you can pre-oxygenate how you want, you can use the device you want. And so you're right there, you're kind of looking at what is the effect. In the BEAM trial, you're looking at what is the effect of the bougie. In the follow-up trial, in the bougie trial, it was what is the effect of broad implementation of the bougie, right? Imprecise implementation of it. And so to me, I think if you're going to use a standard geometry blade or DL, what you can get to is you can approach what Hennepin does, which is 96% first attempt success. I think that's phenomenal. If you're using a hyperangulated blade, you shouldn't try to contort some malleable floppy thing up into the airway.
Right. That's a bank shot. Like, why are you doing that?
It is. Yeah. You might get lucky. And Rich has a new bougie coming out that is rigid enough that you can use with that. I mean, there are some tweaks to it, but I think that in general, you should not try to do that.
Yeah, I think what you said is great, which is that think of hyperangulated as you're going to use the stylet that's designed to work with that.
Yeah.
And standard geometry as you can use a bougie or you should use a bougie?
Yeah, the other thing I would add is that a bougie is an adjunct, not a backup device. So I hear oftentimes, "Oh, I'm going to try a standard geometry VL, and if I fail that, I'm going to use a bougie as a backup." That's not a backup. That's an adjunct.
Yeah, it's interesting. Yeah, I think it's I guess from my perspective, it can kind of be used. Well, I suppose it depends on how you define backup. Classically, the way that I've done it is if I anticipate this is going to be challenging for whatever reason, we have many tools that you can use, lemon mnemonic, there's so on and so forth, your different rules. Then I might kind of load up the bougie ahead of time. And the reason I don't love the bougie is the friggin' back end is always flopping around in my face. So what I try to do is I have a buddy of mine called it like the kiwi grip or whatever, where you take the tail and you stick it through the Murphy's eye. And then you just kind of pull the bougie out. So you got plenty of bougie to go. And then the moment you get the bougie through, you can just flip it out and then go. It looks cool. And it works pretty well. But I think that more often than not, if I'm using a bougie, I'm using it once I've determined that the aperture is so small that I really do need to try to thread something through first and then go over. And in that sense, I guess it's kind of like a backup, but I don't know. Perhaps it's semantics.
That's a different scenario, right? But
Yeah, that's true.
I've tried all those different grips too, and some of them are kind of neat tricks and whatnot. But the bougie was invented for all you see is the epiglottis, and the
Mhm.
coude tip of it gets under the epiglottis, and then you can feel the tracheal rings. If you preload it and all this other stuff, you won't feel those tracheal rings. And so all those tricks are great if you can see the airway. If you see the airway, yeah, maybe you don't need the bougie
We
anyway.
don't
But
need it.
yeah, so it was made for a grade 3 view, which is why I say it's an adjunct and not necessarily a backup device.
I hear you. Yeah.
And so I want to double click on that there. So your point is don't preload it because even though you're saving time, you're losing sensitivity, which is one of the key reasons for it.
Yeah, I mean, look, if you're by yourself, you're kind of stuck. You got to do something, right? So what I think you should do is use it the way it's supposed to be used. And if you're going to preload it, don't contort it in all different shapes. Just load it to where you're still pinching it
Right.
below the ET tube, and so that you can
You
feel the
should be holding bougie, not tube and bougie,
correct,
is what you're saying.
correct.
Yeah.
Yeah.
Yeah. And that's what I found with my little grip, if I set it up correctly, I can still do that because there's enough, because the bougie's so dang long. But I can hear your point if you don't. I mean, it makes sense. Like you'll if you're holding the ET tube, you're losing all tactile sensation.
Yeah. There's another version of that grip where you could just put the pilot balloon, the cuff for the pilot balloon into the Murphy eye instead of folding the bougie over and putting
Oh,
it.
that's clever. Interesting. Yeah. Huh. I'll have to play
We're
with
gonna
it.
we'll have to put some stuff on the website with some of the different grips. We could take some photos and do this. This will be a useful piece of show notes.
Just don't you mentioned coude. Just don't use like a coude catheter instead of a bougie.
Yeah, yeah, exactly.
Right. This is like the problem with Osler inventing half the words in medicine. It actually gets confusing. Yeah. Okay, great. So, bottom line, bougie is your friend in standard geometry intubations. If you're going to use a bougie, use it right, where it gives you tactile feedback. There are many different ways to hold it. This is probably a good example of something where you should practice so that you're comfortable with it, as opposed to kind of saying, I've got a bougie in the room, but only using it when you're really in trouble, because then you're going to be clumsy and unfamiliar with it.
Absolutely. That is one reason. I mean, that's the reason to use a bougie, and that's a reason to routinely bag after induction so that you get that skill. Great opportunities to get that skill.
And it occurs to me that there's some skill transference here too, potentially with surgical airways, that like being comfortable holding a bougie, using a bougie, feeling for rings
Yep.
is kind of a skill that you want to sort of build into your brain. So it's kind of like, I know that feeling.
Yeah. When you use it for a crike, you may not feel the rings though, because it's taking a steep angle and
True.
it'll bend
Good
down,
point.
not up. So, but yes, there's some skill transference.
So again, to make sure that we give this bad boy its due diligence, another controversy, I suppose, that we can unpack here. This is the discussion of your kind of RSI versus awake intubation in the critically ill. And the question would be, should critically ill patients be intubated awake to avoid any sort of peri-intubation collapse? What's your sort of like immediate knee-jerk reaction, Jarrod, to that comment?
Well, I'm largely responsible for that. I mean, I have written about that ad nauseum. I've seen two unintended consequences of sort of my life's work here. One of them is the patient's critically ill and I don't want to make them worse, so I'm not going to intubate. That's not true, right? I mean, you need to do some things differently, not intubate. The other is critically ill patients should be intubated awake. I think most critically ill patients need to be RSI'd. In fact, probably 90+% need to be RSI'd. There is a portion of them who cannot tolerate a period of apnea, or the induction drugs will be the last nail in the coffin. And so who are those two people? On the apnea part, it's really the patient who's got ARDS with refractory hypoxemia and high inspiratory effort. So we were talking earlier about when you sedate somebody, you give them a little ketamine or something like that, what happens to your FRC? So us breathing right now spontaneously, the biggest portion of our diaphragm movement is going to be dorsal in the spinal part of our diaphragm, right? It's the most curved part, so it's going to move the most. If we sedate each other, it'll still be the dorsal if we're spontaneously breathing, only you lose some FRC. That's where the best blood supply is, right? So that's where your best VQ mismatch is. And if you have a high inspiratory effort, and you get all that pendula, remember we're putting people on 100% oxygen, and we get all that pendula flow from the high transpulmonary pressures that are regional.
Cyrus, by the way, can I just interrupt and say that this guy deserves an honorary palm board for using
I was just thinking the same thing.
Yeah.
Another topic well, I'm sure it'll come up eventually, but we haven't talked about it yet.
Yeah, pendula is
So they're already statin 89%, right? And then you take that away and they desaturate quickly. They will not tolerate apnea. This is not the person who has a bad look in X-ray, but they have the non-invasive respiratory support, looks like it's working and all that stuff, right? This is somebody on BiPAP or 60 liters of high flow and they look terrible. That's the person that I'll intubate awake. Hemodynamically, it's the RV failure, right? It's not the patient in shock from a bad left ventricle or vasoplegia. That's a pharmacologic problem. The person that I'm going to intubate awake for hemodynamics is generally the RV failure patient, or the person who's at risk of RV failure, like somebody who's got a really tight mitral valve or something, and you're going to precipitate a pH crisis if you do it poorly. Those are the people that I think need to be intubated awake. And the controversy is not, in my opinion, is that the safest thing for them. The controversy is, am I willing to do it? Because I don't intubate awake very often. I don't really have that skill. This is a stressful situation. I want to fall back on what I do well. So to me, that's the controversy. And this is across the board, right? Anesthesiologists are arguing about this because they're not intubating awake. Emergency physicians aren't intubating awake. We're not doing it all that often. So should this be a core skill that we all do, or should this be a small group of people that become experts at it? To me, that's the controversy.
And maybe before we delve a little deeper, Jarrod, for the sake of our audience, can you talk us through your approach to that awake intubation, what that looks like, what right looks like?
Yeah. So the easiest to describe is the ARDS patient who's doing poorly, right? And they're on high flow, and the argument of, okay, they're on BiPAP, I don't want to take them off BiPAP and put them on high flow, they're going to desaturate. Yeah, they may desaturate a little temporarily, but they're not going to go to zero as if you were to RSI them. So I'll put them on high flow, and then I topicalize them. And the key to success is adequate topicalization. And for me, that's atomized 4% from the RTs in endoscopy, and it's 5% ointment. And if you topicalize well enough, then you generally don't need any sedative. If you do need sedative, I like Precedex. And the way I've come to liking Precedex is, I used to use ketamine all the time, but it is a sialagogue. I mean, you can get increased secretions, number one. And number two, it's too easy to cross that threshold from spontaneously breathing and cooperative to spontaneously breathing but no longer cooperative.
Yep.
And I don't like that. So I'll start Precedex at just some mid-range infusion, no bolus. There's nothing wrong with a tiny bit of fentanyl or a tiny bit of Versed or a tiny bit of ketamine, something like that. Nothing wrong with that. I just like Precedex.
And that's often, like, to your point before, like often these patients who are on non-invasive, they may already be on the Precedex. Like it's not unreasonable to sort of keep them comfortable there while you're preparing all the stuff.
That's right. Yeah. Now there is an argument of, oh my God, they're already sick. They're going to do poorly. I've never intubated awake. What do I do? I think a reasonable alternative is to induce that patient to a supraglottic airway and then either intubate through the supraglottic airway or around it. There's ways to do that, but you're jumping off the cliff with them, and safe apnea is not possible. They've already proven that, right? And so, to me, that's how I do it. But it
And
is,
then which devices are you using for this?
if I'm going to intubate somebody awake, it's with a flexible endoscope. I find that it's more forgiving to inadequacies in topicalization. There is no reason why you can't do a wake VL or a wake DL, but for me, it's a flexible endoscope.
Yep.
If you think about it, it's like it's the area that's touching, right? So
Yeah,
like a blade that's relatively large
yeah,
is putting a lot of pressure on a lot of different parts of the oropharynx, and if any of those aren't optimally
yeah.
anesthetized, they're uncomfortable. As opposed to flexible, like a bronchoscope or whatever, that
Yeah.
is kind of just touching a pinpoint, or maybe touching the back here and the front here, and then going through the cords here.
Exactly. And one of the fears is, okay, now I get the tube through the cords and they're coughing and going crazy. But when you do a cuff leak test when they're on the ventilator, they cough. And then when you inflate the cuff, they stop coughing. And it's kind of the same thing here. They cough, you inflate the cuff, they stop coughing, you put them on the vent, let them breathe some breaths under PEEP as you put them to sleep. And it's kind of a smoother transition.
The other thing you do, you have that working channel, so you can just you could give a little more lidocaine. You could
Yeah,
hit the carina or something like that right then and there as
exactly.
you're getting your additional anesthetics on board, or you're getting the patient off to sleep.
One thing I've learned kind of the hard way is that no matter how cooperative somebody is, soft restraints are often a good idea when you're here, because sometimes people are completely cooperative, they seem totally comfortable, and then for whatever reason, tube through vocal cords is a stronger stimulant, and they just reach for it. So it's always nice to just sort of know that that's out of the
Yeah.
picture, in my opinion.
It takes a lot of coaching, and I wanted to try to see what this felt like, and so I
Ooh.
topicalized myself and everything, and you do get there's a certain amount of proprioception that we have to breathing, and when you topicalize somebody, that goes away, and it can be
Yes,
pretty anxiety provoking, and so it does take some coaching.
As in, you don't feel your own breathing
That's
anymore
right, yeah.
because you're accustomed to feeling airflow.
I had a laryngoscopy done, and he was like, "Well, let's just that my buddy did it." And he was like, "Well, let's take a look at the trachea too. Make sure you don't have like EDAC or anything like that." So I was like, "Yeah, sure, I'm game. Like, I'm tough. I can handle it." And so, I mean, did a good job topicalizing. But man, yeah, the moment we went through, and that was just with the thin scope. It wasn't loaded with an endotracheal tube. But the moment we went through the cords, I was like actively just like holding on to not reach up.
Yeah,
And you're right that when your oropharynx is appropriately topicalized and you can't really feel any of that, it's very unsettling because
it
you're like,
is.
oh my God, I'm suffocating, like
Yeah,
I'm going down.
yep.
And yeah, it's yeah, yeah, it's not fun.
The way I've started trying to get the trachea, I mean, there's a million of ways to topicalize somebody. I kind of told you how I do it, but the last thing I do, they're on high flow, remember? So I'll hockey stick the atomizer and put it over the back of the tongue. As they're taking some breaths in on high flow, I'll just atomize a little lidocaine into that stream. And
Yeah,
I've had good success with it. I have no data to show whether that works or not, but
it sounds cool though.
yeah, it seems to be successful for me.
And let's talk about another kind of related area, which is you're going through the mouth, not the nose. Is that right?
Yeah, if you're intubating awake for obstructive pathology, that's usually in the nose. If you're intubating awake for refractory hypoxemia, that's in the mouth.
Gotcha. Makes sense. I think we could probably talk endlessly about that second case, but let's not do that for now. I think
Sure.
this is good.
Agreed.
So I think, as far as the controversy here, maybe the big controversy is who's doing it and how are they prepared to do it. So maybe we should talk about that next.
Yeah, I this is an ongoing area of controversy across specialties. VL has removed so many airways that would have been intubated with a flexible endoscope that now people just aren't getting the numbers to maintain the skill. But there is a certain portion of patients that need to be intubated awake, either because of terrible anatomy or terrible physiology. And that portion is probably, I don't know, 5%, 2%, something like that. I mean, if you look, it depends on what the underlying etiology is, but it's low, right? So people aren't going to get high numbers of that, and it's a stressful situation, and so they're not going to be
I would
confident.
say that's exactly the worst kind of low frequency thing, though,
Yeah,
because it's frequent enough that you will encounter it. It is assured that in your career you will see it, but it's rare enough that you won't feel like you're an expert, even if you've seen it a couple of times, because they're spaced out by a lot of time, presumably.
absolutely. Especially all these people who get put on high flow or BiPAP for their pneumonia, and then they fail 12 hours later, and now they're even worse off. So to me, this is an unprompted pitch, but I think this is why you go to an airway course, any airway course, right? Stanford's got one, Will Rosenblatt has one, Rich has one, we have ours. To me, this is the reason why you go to an airway course, to get some reps and maintain the skill that then you can go back to your facility and you can take some of those tips and then try it, practice it. I mean, what I actually hear when I do the critical care courses, any pulmonologist is like, great, show me how. I'm good with a bronchoscope, show me how. And then you do an EM course where they've never touched a bronchoscope, and that's a much steeper hill to climb.
It's a great point. Yeah.
Sounds fun. I'll have to get out there.
Yeah.
Welcome anytime.
We should do it at the same time, man. That'll be fun.
Yeah, that'd be super fun. We could do some recording there. We'd have a great time.
Yeah.
All right, let's move on. Let's do some rapid fire controversies now. So this is kind of a golden oldie. Should cricoid pressure be used to prevent aspiration? This is the so-called Selleck's maneuver, where this is not external airway manipulation to change the view. This is just somebody is automatically pushing on cricoid cartilage during intubation. Yay or nay?
Doesn't matter. The literature shows it might make the view worse. It doesn't really prevent aspiration. If you want to do it, fine. If your view's poor, release it.
Yeah. I think it's just one more thing to go wrong.
Yeah.
Less is more.
Agreed.
All right. That was easy.
Yeah.
Next controversy: gastric decompression prior to intubation. So sometimes, you'll hear this literature that like, oh, this person's bleeding, they've got blood in their stomach, you're going to give paralytics and release their lower esophageal sphincter, and then they're going to vomit all this blood. We have to jam an NG tube in to drain it first. What's your take on that?
A bit of a curiosity. The original publication on RSI by Sept and Safar in 72, it was like a 15-step checklist. Part of it was decompressing the stomach with an NG tube and then taking the NG tube out. You had to take it out so that your Selleck's maneuver would work and whatnot. And so the interesting thing is and this, just to let me go on a tangent for a second, the biggest threat back then was aspiration. And that is how this paranoia about aspiration, don't bag after you've induced, all this other stuff, because they might aspirate. That's how this evolved. And why wasn't it desaturation? Because the pulse oximeter wasn't even invented for another 10 years. It wasn't commercially available to even know if somebody was desaturating or not. If they weren't blue, they weren't desaturating. And so that's why the paranoia for aspiration. So I think in our world, in modern airway management, we all have an ultrasound immediately available. So if you just look at the stomach and it's full of stuff, maybe decompress that person. But in terms of, I think maybe there might be, I don't know that it's worth it, because you're right. You may induce vomit aspiration by just putting it in.
And I think, it's very different too, like, depending on what the circumstances are. Like, if you're like, oh yeah, I'm just going to finish my coffee and then we'll intubate this person. You go put in this NG tube and I'll be there in 10 minutes. That's like a pretty risky thing to do, right?
Yeah.
Like if that person vomits, their airway is not going to get actively managed.
Yeah.
If you're in the room with all your equipment, all your meds ready to intubate, and you decide to drain the stomach first, that's maybe a different thing, maybe a little smarter. You could deal with the consequences if it turns out to be a bad decision.
If somebody's got a small bowel obstruction, maybe it makes sense. I don't know. Everyone's on a GLP-1 now. And so is everyone at higher risk of aspiration? I don't know. I think ultrasound is kind of the happy medium there to, if the stomach's full, then maybe consider decompressing it, or at least at a minimum, having the head of the bed up more and that kind of stuff.
I think that's smart, Jared. I mean, I think like I don't know, this is not something that's made its way into my standard practice. I think, you know, uh, there's also the risk, usually you're intubating someone because you have a respiratory concern. And while this doesn't happen often, you can also stick an NG tube in the lung. So like you're potentially buying yourself another complication and you're wasting time in a lot of cases. But I love the kind of pragmatic approach of like, if I'm thinking about it, let me just take a quick look. I can do that pretty easily. And if I don't like what I see, maybe we'll put an NG tube down, or maybe we won't because we just have to intubate this patient. And we'll kind of, take some of these other conservative measures that I think are perfectly reasonable.
Yeah, yeah.
Great. Okay. Maybe for the final controversy, this is kind of a fun one.
Yeah.
Should supraglottic airways be the default over endotracheal intubation during a cardiac arrest? So if you read like the AHA guidelines, they say that, supraglottic airways are preferred in some, I forget the exact language. So actually I'm not going to say if you read the AHA guidelines, but there are those who recommend supraglottic airways, early on in codes because it doesn't require a skilled person. It doesn't pull them to the head of the bed as much, and it's pretty good. Let's say that you are the only doc at a code. Are you going to go to the head of the bed and intubate them, or are you going to stay at the foot and run the code?
I would go to the head of the bed, put in a supraglottic airway, and run the code from there.
Okay.
We all think that we're better than the data. We all think that, I could be super fast.
It's because we are.
But most studies in 2020 or sooner, more recent, that show the duration of intubation, it's something like 70 to 110 seconds. That's a lot of time without CPR. So if you're going to pause CPR, definitely put in a supraglottic airway. If you've got your video laryngoscope there and you can place it, you can intubate without pausing CPR, then fine, maybe intubate. But I think in general, as a default, a supraglottic airway gets you most of the way in most patients most of the time.
I like that. And I like what they call it, like the Lake Wobegon phenomenon, where the camp where everybody is above average. Like that's kind of how we feel reading the literature. Let's say that you have all the toys. So you have your VL, everything's ready. Why not just try to get the tube and then use the supraglottic if there's any trouble?
I don't think there's anything wrong, especially if you're going to, they're trying to bag and vomit coming all over the place. I think if you can do that without stopping chest compressions, or at the next check, if you can do it without delaying the next pulse check, I think there's nothing wrong with that.
And I think that's the key thing too, right? Which is that if you're comfortable intubating without stopping chest compressions, which is something that VL should make you more comfortable with, that's a very different story than, just a few seconds, which is often like 30 seconds plus.
Yeah. That's exactly, you don't want to be sitting there going, I almost got it. A few more seconds. I almost got it. Right. And then all of a sudden they're getting no brain perfusion.
I think there's a couple points that I'm reminded of. One is, when we talked about running codes in a much earlier episode of Critical Care Time, but a big part of running a code is having effective communication. So I think in a situation like this, if I am preparing to attempt to establish an airway, whether that be definitive or not, I usually tell the recorder or tell someone else in the room, hey, like, I need you to keep me honest. I need to know how long I'm actually taking to do this, because in my mind, it's going to be super fast because I'm awesome. But in reality, it may be not super fast. So having someone keep you like honest, I think is really helpful.
An argument for routine supraglottic airway too is that these patients are positioned for CPR, not for intubation.
Right. That's very true.
And so it is going to be tougher just by default.
The geometry sucks. So the one other point too that I'm reminded of is part of the decision for me is communicating again with the person who is currently at the head of the bed, bagging that patient, and try to get an idea of like, how easy is this person to bag? If they're having no issues bagging them at all, even without like an OPA or an NPA, then for better or worse, in my mind, I have no reason to suspect a supraglottic airway is not going to, get the job done.
Yeah.
But if they're having a lot of issues bagging, and maybe I'm thinking there could be something down there that I need to visualize or something along those lines, then maybe I'm leaning a little bit more towards trying to establish a definitive airway, not just to establish the airway, but also for a potential diagnostic benefit of like, why are they having difficulty bagging?
Right. Yeah.
I guess one thing I would add to this discussion is, why am I the one deciding? Because I think in an ideal world, by the time I get to the code, because I'm rarely the first person there or the second or the third, why isn't there a supraglottic airway already in? I think maybe that's the thing to move towards, which is that it shouldn't be a choice once this whole team is assembled. It should just be done as soon as somebody can do it.
Yeah, this came up. I was consulting or kind of advising a hospital system about should we have RTs intubate this, that, and the other, and it's the code patient. And I said, well, I think the best thing you could do is just, if an RT responds to a code, just put in a supraglottic airway and restore ventilation.
Right, exactly. The 90% solution done really quickly is
That's right.
probably better than the 100% solution that takes a while.
Yep.
And it also gives you information, right? I mean, like the people where the supraglottic airway is not adequate, where you're not getting good end titles, or
Yeah.
you're getting vomit up in it, whatever. Like that's a situation where you need to prioritize a different airway potentially.
For sure. And these second generation supraglottic airways that don't have an inflatable cuff and that kind of stuff, they're so easy to put in, and they're not perfect, but they are so reliable that, in most patients, most of the time, they'll get you most of the way. And I think they'll probably save more lives than routine intubation in cardiac arrest.
Love it. So I think the takeaway here is, even though we see ourselves as airway experts, whatever that means, sometimes it's the perfection is the enemy of the good. Better to use the device which is going to get you most of the way there fast, and then you can make a decision about it, as opposed to just like I don't know.
Yeah.
Sometimes there's like this almost obsession at the head of the bed during a code with getting the tube, and that sort of subtracts from CPR quality and med administration and everything else.
Yeah, I guess my takeaway for this entire episode would be that, there are certain things that get you most of the way in most patients, right? You want to pre-oxygenate with BiPAP, that gets you most of the way in most people. You want to use etomidate or ketamine, that gets you most of the way in most people. The same thing with VL, that gets you most of the way in most people, and the leftover needs an awake intubation. And then same thing with a supraglottic airway, and the two standard deviations, or standard deviation and a half, however you want to look at it, that's where you get anatomic difficult airways, physiologic difficult airways. That's where you really have to start personalizing your approach, and things become that's where people become experts, or at least experienced specialists in things.
I think that is the perfect note to end on, in fact.
All right, folks. Well, today we had a great sit-down episode with Dr. Jarrod Mosier. I think he kind of summed it up nicely right before that audio transition, but I think the recurring theme for me is this idea that the enemy of good is better. And let's maybe just strive to get most of the way there in the vast majority of our patients, rather than striving for perfection. Jarrod, any other take-home points or anything else you'd like to plug before we sign off for today?
No, I appreciate you guys having me on. Hopefully I didn't take up too much oxygen. Hopefully you'll consider checking out the book. Hopefully you'll consider checking out the Airway course. But whether you do our course or any other course, just do a course periodically so that you can keep your skills up.
And one more time, Jarrod, remind us when y'all's course is, your next one. It's in San Diego, if I remember correctly.
Yeah, the next one is mid-November in San Diego.
Perfect. Awesome.
Good time to go to San Diego. Not that there's a bad time to go to San Diego.
No, man. Yeah. If I weren't in the middle of a move, I might have to jump on that one, but hopefully the next time.
All right. Well, big thanks to our guest, Dr. Mosier, for sharing his wisdom with us. Big thanks to all of our listeners and all of the people who have left us 5-star reviews, those who have shared the podcast, etc. Just like to remind everybody that we have comprehensive show notes for every podcast, and we will for this one as well, on our website, www.criticalcaretime.com. There's just links to studies, infographics, pictures, etc. So if you like the show, you should go there. While you're there, you should subscribe to our mailing list, and leave a comment, as long as it's nice. Cyrus is still hurting from a mean comment that was left.
Yeah, I cry myself to sleep every night, and so thanks for that. But also, I think this is a great episode for a little infographic, like do this, not that, which I think we could put together, which would be nice, and nice little posts that could go up in resident workrooms, things of that nature. So we'll try to get that out there with the release of this show. Speaking of, we hope you enjoyed the show. And if you have not already subscribed, please do that. Give us a like. Like Nick said, those 5-star ratings are awesome. It certainly helps us expand our audience. It means the world to us.
Yeah, and then follow us on social media. We're on Twitter, X, Instagram, Threads, Blue Sky, LinkedIn, et cetera, et cetera. You could find us at some permutation of @CriticalCareTime or @critical_caretime or whatever. You could also get us individually on Twitter at Nick M. Mark, @Askins_Razor. Jarrod, are you a social media person, or do you wisely steer away from these things?
I am on Twitter. I'm not super active on it, but I am on it. Yeah, it's at Jarrod Mosier.
There you go.
Before we go, we'd like to thank all the incredible members of our podcast team for helping to make the show possible. We'd also like to thank our production team over at Podpaste, and last but certainly not least, Kurt Belknap for our awesome theme music.
All references to patients or encounters are modified to be HIPAA compliant. I don't think we had any cases in this episode, but if we did, any similarity to real world would be purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. Get somebody qualified to manage your airway. Don't just listen to this podcast. Thanks for listening. I'm Dr. Nick Mark.
And I'm Dr. Cyrus Askins. So long until next time.